I'm Dr. Beverly Coleman, Professor of Radiology at the University of Pennsylvania Medical Center in Philadelphia, and today we're going to discuss obstetrical pitfalls when you think something is wrong. Pitfalls in obstetrical ultrasound when you think there's something wrong. Today I'm going to try to focus on 6 common ultrasound findings that you often encounter when evaluating second and third trimester pregnancies. These include, as you see listed here, choroid plexus cyst, ventriculomegaly, echogenic intracardiac focus, prominent thymus, mild renal pyelolectasis, and echogenic bowel. We'll begin with choroid plexus, and one of the first questions we should consider is the finding real or not real? Choroid plexus cysts are very common, occurring in approximately 1% of all second trimester scans. They may be single or multiple, clustered, unilateral or bilateral, and even septate. We know that these tiny fluid collections result from the infolding of the neural epithelium, which traps CSF fluid in cells. Normally, the choroid plexus is heterogeneous with tiny little lucencies, and it is prominent in the first trimester but begins to recede thereafter. Here's an example of a case, and you can see that the sonographer has measured the entire area of the ventricles posteriorly. Do you really see true choroid plexus cysts? Are these pseudocysts? And if so, is this an isolated finding or not? This happens to be the daughter of one of our sonographers who does detailed obstetrical sonography. And when she saw the choroid plexus cyst in her daughter's scan, she became really upset. And we talked about whether there were other interventions needed, such as amniocentesis. And after doing a thorough check of the pregnancy, we decided the choroid plexus cysts were isolated and of no particular concern. And on the screen in front of you is Anya, the result of that obstetrical examination. Here's another case of bilateral choroid plexus cysts. You can see that there are discrete, tiny anechoic areas within the choroid plexus bilaterally. Here is an example of how we measure these tiny cysts. The cursor should be placed inside to inside, and it should be a discrete sonolucency that you can describe in more than one plane. And here we can see the measurements, 2 adjacent tiny cysts, one in the 5 millimeter range and the other in the 3 millimeter range. A true choroid plexus cyst is, as you see outlined on the prior scan. The size threshold ranges from very tiny at 2 millimeters up to 14 millimeters. The criteria for diagnosing a choroid plexus cyst is that in theory they should be greater than 2.5 millimeters in early pregnancies before 22 weeks and at least greater than 2 millimeters thereafter. Otherwise, these tiny lucencies should probably not be dictated as a choroid plexus cyst. There is no follow-up indicated in these cases, since in approximately 90% of the cases, they will be all gone by 26 weeks and virtually 100% will be gone by about 28 weeks of gestation. Here's an example of another patient where there are bilateral choroid plexus cysts that are large in the 6 to 8 to 7 millimeter range. Large choroid plexus cysts are more worrisome, but only if they're greater than 1 centimeter in diameter. Isolated cysts usually occur in the globus. As I stated before, they are often transient, and there's been no real correlation with laterality. What we get excited about is that in a very small number of cases, less than 1 in 400 patients that are low risk will have a significant risk of aneuploidy. We know that there is a known association with choroid plexus cysts with trisomy 21, and that's what we are most concerned about. The majority of those cases, however, will have lots of other abnormalities associated with the finding of the CPC. If there is a CPC with another minor marker, this increases the patient's a priori risk about 20%. And if there is a major ultrasound marker, about 50%. An isolated choroid plexus cyst has no real association with trisomy 21 unless there are other markers seen. Here's an example of a patient who presented with a question of double bubble, and the issue was in the finding of duodenal atresia, what are other findings? Is it true atresia or could it be stenosis? And is this family at risk? And on the outside scan, the absence of the nasal bone was missed, and a very tiny involuting choroid plexus cyst is still present unilaterally in the right CPC area, and this patient had a proven diagnosis of trisomy 21. So what to look for if we see an isolated cyst, whether bilateral or unilateral? We'd like to watch the hands and feet. This is the one time you want to clearly do a detailed evaluation of the heart, looking at the outflow tracts, and look at the fetal face. Here's an example of a patient with isolated choroid plexus cyst. When we look at the upper extremities, we can see that the hands are in fixed extension with no evidence of fisting, which is what we would worry about in a case of trisomy 18, which is the proven diagnosis in this case. And if you notice on the 3D, there's active fetal movement, but the hands are persistently fisted because this is a fixed neuromuscular abnormality. This fetus had bilateral, very large choroid plexus cysts, as well as congenital heart disease with the large VSD that you see here. So what are the potential pitfalls and mimics of a true choroid plexus cyst? Well, there could be a pseudocyst where it does not fit the size criteria. There can be mild ventriculomegaly, actually masses, or hemorrhage in the region of the choroid plexus. Here's a patient who has a very heterogeneous appearing choroid plexus, and notice that there are tiny little lucencies, some of them linear, others oblong and ill-defined, but this represents a case of pseudocyst, and these tiny echogenic spaces should not be measured and reported as a true choroid plexus cyst. This is a case where there is a tiny little choroid plexus cyst, less than 3 millimeters, but on the contralateral side there is a punctate echogenic focus, and here you can see that here on the left. This is a patient who had focal grade 1 germinal matrix hemorrhage with choroid plexus hemorrhage on the left, and the tiny choroid plexus cyst on the right. A choroid plexus papilloma, generally these tumors are very large, echogenic masses. Here you can see an example of one, and there are tiny little cystic spaces, but unrelated to the finding of a choroid plexus cyst. And notice that this tumor has vascularity, which you should never see in the setting of a choroid plexus cyst. Now let's move on to ventriculomegaly. I think the real issue when there's a question of what is going on with the ventricles is there true enlargement, or could this be a variant of normal? It is important to make sure we always make the measurement of the ventricles from the internal walls and in the true standard axial plane. Normally, as you know, the diameter should be about 7 to 8 millimeters, and anything greater than or equal 10 millimeters is of concern. In addition, if there is a dangling choroid plexus where the glomus is more than 3 millimeters separated from the medial wall, even though the measurements are not exactly at 10 millimeters, it can be cause for concern. Similar to choroid plexus cysts, ventriculomegaly is a common finding on second and third trimester examinations, and our job as sonographers is to determine the etiology and whether this is a finding of clinical significance, and if so, how severe. We categorize ventriculomegaly as mild, using a measurement of 10 to 12 millimeters, moderate, greater than 12 to 15 millimeters, and severe, greater than 15 millimeters. Here's an example of a case that turned out to be proven idiopathic ventriculomegaly. We can see that the ventricle measured inside to inside at the region of the glomus is just over the 10 millimeter range. And here's another patient where we can see the measurement is less than the 10 millimeter range at 9 millimeters. However, there's a 5 millimeter separation of the glomus of the choroid plexus, which is non-dependent and shifted away from the medial ventricular wall. So what to look for when we're assessing a patient for possible ventriculomegaly? We want to look carefully at both lateral ventricles and the areas of the ventricles, including the germinal matrix and choroid plexus for possible hemorrhage, and the ependymal lining of the ventricles. We want to check the third and fourth ventricle and examine all of the midline structures. Here is a case of proven idiopathic ventricular asymmetry. When the ventricles measure differently in size, more often the left is larger than the right, as in this case, about 8 millimeters compared to 3 millimeters, both within the normal range. However, you want to always compare that by using different views. So this is a coronal view showing the asymmetry that persisted. We have a normal third ventricle, normal midline structures, beautiful corpus callosum, cavum septum pellucidum, and cavum virgae. This was a male fetus, and they tend to have more ventricular asymmetry compared to females, and their ventricles often tend to be slightly larger. So for further evaluation, we want to characterize the severity of any case that we diagnose as true ventriculomegaly. Is this mild or borderline enlargement, in which case 90% may be idiopathic, with a 4% incidence of chromosomal abnormalities, particularly trisomy 21 and 18. We want to determine the level of obstruction if there is indeed obstruction present. Assess the gender, specifically because of the male-female ratio of mild ventriculomegaly, which is about 3 to 1. We want to see if we feel that this could be idiopathic, because approximately a third of those cases will resolve. And in doing our detailed and further assessment, we want to look for the causes of ventriculomegaly, which are all of the entities that you see listed here. Here's an example of asymmetric cerebral ventricles, where we can see that the right ventricle is slightly larger than the left, and that persists on these coronal images. And if you notice, there is sort of heterogeneity and lobularity of the region of the germinal matrix. This is a very early grade 1 germinal matrix hemorrhage, which was proven at birth. Here's a case of mild ventriculomegaly, where the ventricular atrium actually measures less than 10 millimeters at 9 millimeters. However, there's more than a 3 millimeter deviation of the choroid plexus from the medial ventricular wall. And if you look here on the coronal views, you can see the mild prominence of the ventricles posteriorly. Looking further for etiology, we can see that there is inferior vermian hypoplasia with vermian tissue here, but communication of the cisterna magna to a mildly dilated fourth ventricle. What are the pitfalls and mimics of ventriculomegaly? Well, we can think the ventricles are dilated when they actually are not, due to artifact in the far or near field. We can see other cystic lesions in the cranium and misconstrue those as representing ventriculomegaly, and these can be normal or abnormal structures. And finally, a large choroid plexus cyst can be confused with a dilated ventricle. Here's a patient who looks on this oblique view as though there is a dangling choroid plexus. But when we line up the brain and do the standard true axial view, you can see the ventricles barely measure 7 millimeters, and this is pseudoventriculomegaly. Here's a case that was referred for a possible dilated third ventricle, and this is the region of the cavum septum pellucidum that you can see here that extends back and into the region of the cavum virgae. Here on the sagittal view, we can see a normal corpus callosum, cavum septum pellucidum, and cavum virgae, all normal midline structures. So this is not a true finding. The cavum velum interpositum cyst, this is a tiny little focal cystic area, which is a variant of normal and of no clinical significance. It was referred in this patient as a possible dilated third ventricle. We can see our normal corpus callosum and midline structures. This is an instance of large choroid plexus cyst. And here we can see that the cystic area is not actually the ventricle. This was referred in as ventriculomegaly, and the sonographer failed to notice that this is the region of the choroid plexus here that's echogenic. And if you scan back just a little farther, We can see behind the glomus of the choroid plexus, the ventricle actually measures 7 millimeters. Another case of very large bilateral choroid plexus cyst confused as ventriculomegaly. As we do a further detailed evaluation to look for the etiology, we see that there is myeloschisis with a flattened spinal defect without a measurable sac. The cord is tethered to the site of the defect, and when we turn transversely at L5, we can see that there's wide splaying of the vertebral processes in a patient with, again, an open spinal defect. Let's move on to echogenic intracardiac focus, another aggravating feature that can be seen on ultrasound examinations. And the question is this of significance or not? EICF can be seen in up to 8% of second trimester scans. There are ethnic influences, and it has been reported that these can be more common in those of Asian or African descent. We should use specific criteria to make the diagnosis, and again, measurements are critical. These ought to be tiny echogenic foci that don't really shadow and measure less than 3 millimeters. By definition, they ought to be bright as bone. They should be reproducible and visible in multiple planes, and typically are best seen on the axial view with the apex pointing forward and the fetus lying supine. Here's an example of bilateral ventricular EICFs, a tiny one in the right ventricle and the left ventricle. Different patients, you can see that the measurements are under 3 millimeters in all of these cases. What are we looking at when we see these tiny structures? This represents papillary muscle mineralization, and pathologically these have been evaluated and shown to be fibrous tissue aggregates with punctate dystrophic calcifications. They're most commonly seen in the left ventricle approximately 78% of the time, 18% in the right ventricle, and 4% of the cases may be bilateral. These can be multiple or solitary echogenic foci. Here is an example of a scan that was done in my godson's wife who was pregnant, and I received a desperate phone call with tears in the whole works because of the finding of an EICF and an umbilical cord cyst and possible mild ventriculomegaly. And here we can see that there is a punctate, tiny echogenic focus in the left region of the left ventricular outflow tract. Here is a normal ventricle that's barely 7 millimeters with some asymmetry, 5 millimeters on the other side, but not true asymmetry because it's not at least 3 millimeters different. And this turned out to have a normal outcome. Here is my godson's son now, and this is Biko coming to visit me in my ultrasound laboratory at the University of Pennsylvania. Here is a clip again of a case that was referred in as possible EICF, and you can see that there's more than one tiny echogenic reflector on the cine clip. Some are real or not real, and the ones that are true have to be, again, as bright as bone and persistent and seen in more than one plane. And the important thing is to look for other associated abnormalities. There is a known association with aneuploidy, and EICF can be seen in trisomy 21 and 13. There can be a 1.8 times increased risk over a priori risk for patients with trisomy 21. And these EICFs can be seen in 18% of Down syndrome fetuses. Interestingly, much more common in trisomy 13 fetuses. However, we don't encounter trisomy 13 cases as often as we do trisomy 21 cases. In actual fact, 3 to 5% of euploid fetuses may actually have EICF. If there is a finding of EICF along with hypoplastic left heart syndrome, this can be very concerning for trisomy 13, and we want to look for other anomalies such as musculoskeletal findings in those patients. The important thing is to differentiate the routine patients who should not be worried from those patients who may need to go on for further workup. If you have a patient less than 35 years old with an isolated EICF, in theory, there's basically no risk in these patients and no further workup is really recommended. There is an increased risk when the EICFs are large and bilateral and there are other signs associated. Here's an example of a patient with proven trisomy 21. Here we can see the heart with bilateral pleural effusions. There's scalp edema, a hypoplastic nasal bone, and a very shortened femur length. But interestingly, this patient did not have an echogenic intracardiac focus. So what do we want to do when we're doing this examination for this finding? We want to scan from multiple angles. We want to watch closely in real time because interestingly, EICF may also be a possible marker for structural cardiac anomalies. So in these cases, we want to spend the extra effort to look for other parts of the cardiac anatomy, including the inflow and outflow tracts, the aortic arch, the ductus arch, and so on. Here's an example of bilateral EICF in the finding of tetralogy of Fallot. And I believe this clip shows an excellent demonstration of the overriding aorta that we can see here. Notice that in this plane, looking at the overriding aorta, we don't really see the EICFs as well, but here is another plane where we can see clearly the tiny echogenic foci, which we saw in more than one plane. This was a proven case of 22q deletion and a patient with bilateral EICFs and proven tetralogy of Fallot. Are there normal structures that can mimic an echogenic intracardiac focus? And what you see before you is a list of findings, including the moderator band, various valves, various calcifications, either on the septum or on the myocardium, and even echogenic structures outside the heart can be confused as an EICF. Here we can see a tiny echogenic focus that's not really as bright as the adjacent rib or the sternum. This is a papillary muscle reflector and not a true ICF. Here is a tiny reverberating reflector off the ventricular wall in a case of right ventricular hypertrophy, again, not a true EICF. This is a pseudo-EICF, which is an echogenic area that is associated with a valve and a specular reflector there, and not a true EICF. This is a patient who was referred for bilateral EICF, and here you can see that there is a more coarsened shadowing and larger than expected echogenic focus, a tiny EICF in the left cardiac ventricle there, but this is actually subdiaphragmatic right at the level of the diaphragm, and it represents one of those tiny echogenic foci that you may see in the upper abdomen, either on the right or the left quadrants, generally of no clinical significance, again, as an isolated finding, and this is near the area of the heart, but clearly outside of any of the cardiac chambers. This is a really rare and unusual case of idiopathic infantile arterial calcification. In this case, there were multiple echogenic areas that you could see in the heart on real time, which we can see here. The heart was enlarged with pericardial effusions. You can see reflectors off of the base of the aortic root and off of the regions of the valves, but also notice that there is extensive calcification of the abdominal aorta down into the region of the pelvis. Here's the area of the iliac crest, and notice that there's extensive vascular calcification throughout both kidneys. Let's move on now to a prominent thymus. The question here is this really a mass lesion or something to be concerned about? The thymus, as you know, originates from the third branchial cleft, descends into the mediastinum at about 12 weeks, can actually be seen on relatively early scans at 14 to 18 weeks, but generally it becomes a problem and can be confused as a mass when you're doing patients later in pregnancy, in the late second and early third trimester. Here's an example of a patient who has a normal thymus. And here you can see between the areas this hypoechoic sort of marbly appearing structure in the anterior mediastinum. No true mass effect on the heart or the lungs, but depending on how you rotate the transducer and obliquely scan, it can appear prominent. This patient was sent for an outside diagnosis of right CCAM. And here we can see that there's a discrete mass here, but it is an anterior mediastinal mass, not a right chest mass arising from the lung parenchyma. Here is a normal lung, here's the thymus, and here is a normal heart, the contralateral left lung. This is simply a normal thymus gland that was visualized later in pregnancy and confused as a parenchymal mass. The best way to see the thymus, again, is on that four-chamber heart view when the fetus is supine with the apex up towards the transducer. It, again, lies anterior to the great vessels. There are two lobes. When you're scanning patients in the mid-second trimester or earlier, generally it can be sort of echogenic or isoechoic to the lungs, but becomes more and more hypoechoic over time. And by the time you get to the third trimester, it's clearly hypoechoic relative to the normal lungs. And here you can see a hypoechoic thymus in a well-developed fetus greater than 27 weeks. Here's a more echogenic lung tissue. And again, this should not be confused as a mass lesion. When we do a transverse or axial view through the upper mediastinum, again, here is a thymus in the midline, anterior to the heart and the great vessels, a totally normal finding, and it should not be of concern. Are there other lesions that can mimic this appearance? A goiter typically is higher in the neck and not in the region of the mediastinum, tends to be vascular. Intracardiac masses can occasionally be confused, but a congenital cystic adenomatoid malformation, as we previously discussed, arises within the lung parenchyma and should never be confused as a thymus, and the thymus should not be confused as a CCAM. Here's an example of a patient who has a mass. If we look on the 3D, here we can see this mass is higher in, and not in the chest, but actually in the neck region, not even in the superior mediastinum. We turn on color Doppler, and it's a hypervascular lesion or goiter associated with thyroid disease in the mother. Here's a more echogenic mass, clearly intracardiac, not in the region of the mediastinum. This is a cardiac rhabdomyoma situated in the right ventricle. Let's move on to renal pyelectasis. And I think, again, this is another feature where the issue of size becomes critical. Renal pyelectasis can be seen in a significant number of normal second trimester scans. It's been estimated at approximately 2 to 3% as compared to 17 to 25% of trisomy 21 cases. Most often, renal pyelectasis is a normal variant, more common in males than females, and particularly of no real significance if there is not associated caliectasis. In our practice, we use a right pelvic diameter greater than 4 millimeters in the second trimester or greater than 7 millimeters in the third trimester as our cutoffs. We measure the AP diameter usually on a transverse view. Here you can see this is a second trimester case where the pelvis measured 5 millimeters. On the other side, it was not measurable. We always turn to do longitudinal views to compare the appearance of the kidneys to look for normal intrarenal anatomy. This was a patient with gastroschisis. You can see some dilated intra-abdominal bowel loops with asymmetric renal pelvis, basically normal, of no clinical significance. Mild renal pyelectasis is often transient and idiopathic and can change even during one scan or from scan to scan. We know that it can be associated with fetal bladder filling, reflux, and various variants, including maternal hydration. Often the finding can be bilateral and symmetric, and it's more likely to progress if it's unilateral and asymmetric. Here's a patient who had the fetus with the bladder full and changing over time. And these are various measurements of the renal pelvis to show you the different numbers that we can get. Almost up to 4 and 5 millimeters here, and then back to 4 and 3 millimeters here, with changes depending on what is happening with the voiding situation in utero. Our concern for mild renal pyelectasis is likely again due to the fact that it is a minor marker for trisomy 21, with a 1.6 times increased risk when seen early in pregnancy over the a priori risk of a patient who, again, is greater than 35 years of age with concern for trisomy 21. 1.7% of fetuses with mild renal pyelectasis will have aneuploidy compared to about a third as many, or 0.46%, if there is isolated renal pyelectasis. There can also be a recurrence risk with the subsequent pregnancy. And other than trisomy 21, rarely renal pyelectasis can be associated with other aneuploidy type situations. Renal pyelectasis is something that can be managed usually before pregnancy, and we don't really recommend amniocentesis, and particularly is that there is no indication if it's an isolated finding, particularly after a thorough assessment of the patient's maternal and baseline risk. Here's a patient with mild renal pyelectasis, and notice that there are other findings with absence of a nasal bone, heart abnormality. This is a common AV canal or endocardial cushion defect, and a short femur length, other markers, which makes this patient at more increased risk for the possibility of trisomy 21, and this would be a patient you would want to do amniocentesis on. So what do we look for when we're trying to decide if this is true renal pyelectasis or not? What we generally do is make the measurement of the renal pelvis if we see any fullness, and then we turn to do a longitudinal view to evaluate for cholelectasis. We monitor the bladder for change, we look for intrarenal anatomy, we assess the gender, and then look for other findings. Here's an example of isolated, very mild renal pyelectasis, 5 to 6 millimeters. And if you notice, turning on the sagittal view, you can see the fullness of the renal pelvis, but no distended infundibulum or calyces, and this patient went on to a normal outcome. Greater than 4 millimeters and less than 7 millimeters, 80% of those renal pelvises will likely resolve in utero, and only about 17% will persist after birth, and of those, very few need a postnatal evaluation. Renal pyelectasis much greater than 7 millimeters rarely resolves in utero and could possibly progress. So when we think it is significant, we want to follow those patients. And again, even in those cases, a significant percentage will resolve postnatally. That leaves us with patients who have persistent dilatation after birth, and those are the patients who have to go on to a more detailed workup, usually starting with an ultrasound examination as a neonate. Here's an example of a patient with very mild renal pyelectasis. Here you can see there's no distension of the calyces, normal intrarenal anatomy with medullary pyramids, and this was in association with a congenital diaphragmatic hernia. Here we can see the liver is situated in the chest, and there is mediastinal shift with the heart pushed over. So it was a case associated with multiple anomalies. Again, a left congenital diaphragmatic hernia. On this view, we can see bowel. We can see that there are bone abnormalities, there's talipes, and there's a 3D image showing absence of one of the ribs. What are the pitfalls in assessing mild renal pyelectasis? There are normal variants, such as an extrarenal pelvis, a very mild UPJ obstruction, prominent hilar vessels, but rarely do obstruction cases present as mild renal pyelectasis. Here's an example of an extrarenal pelvis. By definition, the pelvis should be outside the confines of the renal parenchyma, and here you can see the renal tissue here. So this is an extrarenal pelvis that measures a little bit more than 4 compared to the contralateral side, that's 2. Again, in a troublemaker, that's a male fetus. Here's a left mild renal pyelectasis compared to a much bigger renal pelvis, that's a right congenital UPJ obstruction. Notice when we turn on this case, on the longitudinal view, you can see that there's fullness of the infundibulum and dilatation of the calyces. We're going to end this talk discussing echogenic bowel, and I think the real issue with this finding is the bowel definitely bright or not? It's important to remember that meconium occurs in the bowel as early as 16 to 8 weeks of gestation. What it is actually a mixture of secretions, including amniotic fluid cells. It is probably the least common of all of the findings we will talk about today, being seen on less than 1% of second trimester cases. It can be seen in intrauterine growth restriction, infection, bleeding, and so forth. And echogenic bowel can have a homogeneous appearance. I think the transducer we're using is important, and note that it can be a nonspecific finding and also transient. Echogenic bowel can actually be graded as 0 to 3. I think the grades 0 and 1, which refer to less than the liver or greater than the liver but clearly less than the bone, are basically within normal limits. And grades 2 and 3, which were equal or greater than the bone, are potentially abnormal but not definitely abnormal. Here's a patient who presented with an abnormal triple screen, and here we can see that the bowel is brightly echogenic and clearly equal to at least the osseous structures that you can see come into play on various images that we see here. Notice that this patient is not growing appropriately, approximately 2 weeks delayed, with a number of the biometric measurements that we see here. And this is an example of significant intrauterine growth restriction with what we call grade 1 echogenic bowel. Grade 2 echogenic bowel is at least equal to bone, and here we can see that again we have the iliac crest here. Here's our echogenic bowel there. As an isolated finding, what is the significance of that if there is no other finding, and often it is minor. Here's grade 3, which means more echogenic than bone, and here we can see that this is actually the region of the sigmoid colon. We can see the bowel extending up, and this is large bowel up to the area of the splenic flexure. Here's bowel all the way down to the pelvis in the region of the rectosigmoid colon, and here we can see again a view showing this very bright echogenic bowel that is grade 3. What do we look for when we feel like the bowel may be echogenic? Well, one of the first things we want to do is we want to pay attention to the transducer that we're using, because higher frequencies can falsely increase echogenicity. Then we change to a lower frequency and check the bowel at least with a 5 megahertz transducer. True echogenic bowel by definition is usually focal. It's often in the lower abdomen, and even when it's a finding that's isolated, you have an adverse outcome in about 6% of cases, but when it's mixed with other findings, depending on the significance, you can have up to a 50% adverse outcome. Again, the issue with echogenic bowel is trisomy 21. With 1 to 2% echogenic bowel cases having trisomy 21 with a 6.7 times increased risk over a priori risk. So it's important to check for a number of other markers. Here's a patient with severe intrauterine growth restriction, 3 to 4 weeks delayed, and you can see the bowel appears mildly echogenic. This kid is under distress. There's a lot of meconium staining. The kid was delivered early. Here you can see a few dilated bowel loops. And in these patients, sometimes it's better to determine if early delivery would end up in a better outcome rather than waiting. Here's a case of complete heart block with bowel ischemia. You can see how the heart is beating in this image, where the heartbeat is not being transmitted normally from the atria and ventricles, and notice that there is ischemia of the bowel, which can be echogenic, and here we can see brightly echogenic bowel at even greater than the bony structures in some cases, very echogenic kidneys, and we know that this kid is anemic because we can see a very spiky, elevated peak systolic velocity in this middle cerebral artery graph. Pitfalls for echogenic bowel or pseudoechogenic bowel and meconium peritonitis. Here's an example of bowel evaluated with a 12 megahertz transducer with a 5 megahertz transducer. Here's a view where we can see fluid in the rectum. Notice that the colon does not appear particularly echogenic. When we switch from the 12 megahertz to the 5, the bowel is clearly within the normal range. This is a case of meconium peritonitis, and here in this case we can see that the bowel is echogenic along the walls, but normal sort of hypoechogenic or fluid-filled bowel loops, but only echogenic along the walls. But pay attention to the fact that there are plaque-like echogenic areas lining the peritoneal cavity on the region of the left upper quadrant and adjacent to the liver. This is meconium peritonitis due to in utero bowel rupture. When you have meconium peritonitis, you can have walled-off pseudocysts, and often the walls of those pseudocysts can be brightly echogenic, in addition to the plaque-like echogenic areas on the surface of the liver that we see here. This patient actually had 2 pseudocysts. And you can have associated ascites. This is a case of echogenic foci that are not echogenic bowel loops, but this is echogenic meconium that is freed from the bowel, plaque-like on the surface of the liver, associated with the finding of ascites that we can see on this clip. So in conclusion, I'd like to emphasize the fact that high-resolution ultrasound allows us to detect a lot of very subtle findings, actually earlier than we've ever seen them before. And these should not be considered anomalies, but really structural features. And they include at least 6 entities: CPC, ventriculomegaly, EICF, the thymus, mild renal pyelolectasis, and echogenic bowel. Because these are commonly encountered, the most important things for us is to determine when there is significance and when the patient can be treated more conservatively and the parents are not worried with us overdiagnosing or misdiagnosing some of these soft signs that can be misinterpreted. And I think that application of very specific criteria, including precise measurements, will help us improve the prenatal diagnosis a number of these structural features. Thank you for your attention.